So, hi everyone, I'm Andrew. So I'm an analyst at the Health Foundation here. I've been working for about 6 months or so. So this is my kind of first outing in kind of talking through the work that we did. And hopefully it all makes sense and hopefully it's okay. If you've got any questions, feel free to just throw them out during this. It probably is about 15 minutes of a kind of presentation thing. So if you think anything after that, happy to have a kind of wider discussion on some of this as well. So what I'm going to talk to you today is our publication that we produced or kind of published back in December. And so that is what's driving increasing length of stay in hospitals since 2019. This really came on the back of work that we published back in June, just as I was beginning at the Health Foundation, which showed that between 2019 and 2022, the number of adult patients admitted to NHS hospitals for emergency admissions fell by about 521,000. And although we saw the admissions fall, we actually saw the total number of bed days increase by about 258,000. So what that meant is that on average, each person admitted to hospital as an emergency admission had an extra an increase of 1.1 days in hospital, about a 14% increase. And as Rachel, as you kind of suggested throughout this already, if that means that people are spending longer in hospital, it means potentially fewer people are being seen in hospital and can have all sorts of other negative impacts as well. So really, the big driver for us was then, well, what has caused this increase in average length of stay, particularly as it's gone up about 14%, so quite a sizable increase. That paper back in June was quite helpful in articulating a kind of more honed in question. And that was through this particular graph here. Sorry, this will be lots of just graphs and me talking about stats and things. Hopefully that's all right. So this graph shows the change in length of stay amongst emergency hospital admissions between 2019 and 2022. What the kind of key takeaway point of this is that change in length of stay isn't uniform. So up to 14 days in length of stay, we actually saw fewer adult emergency admissions in 2022 compared with 2019. And then over 14 days, we saw more emergency admissions lasting longer than 14 days in 2022 and compared with 2019. And what this kind of analysis suggested is that we're seeing, well, obviously more longer stay admissions and fewer shorter stay admissions. And without any change in patient composition or any other factors in the system, what this kind of increase in longer stays, reduction in shorter stays, just by basic arithmetic, what that will inevitably lead to is a longer average length of stay. So we were able to kind of hone this question a little deeper into not just what has caused that increase in length of stay, but really what's caused an increase in longer stay patients in 2022 compared with 2019. And I'm sure all of you have got quite a few suggestions and probably have analysed a lot of this already yourselves, but we can have had three lead causes or kind of potential causes for that. So the first one was new care models away from hospital wards. So same-day emergency care, which I think emerged kind of post-pandemic, that potentially would reduce the number of people that are admitted to, would reduce the number of people admitted to hospital and predominantly shorter stay admissions. So that would kind of reduce that point. We've also seen things like virtual wards or in Scotland, hospital at home, increasing quite substantially since the pandemic. And so again, does that reduce length of stay or does that stop people coming into hospital in the first place by being treated outside of the system, which again would kind of change that ratio that we saw there. Another factor, and perhaps more ascribed for people that work in the system itself, is barriers to patient flow within hospitals. So we saw this pre-pandemic, but perhaps now even more acutely post-pandemic, is the elevated levels of bed occupancy. So I think pre-pandemic sitting around high 80%, low 90% in terms of bed occupancy. Now it's definitely in the kind of mid 90% across the country. And what that means is with the system and the hospitals running even hotter, it becomes harder and harder to find beds in the right wards for patients. So patients might be staying in one ward before being transferred into another ward. And before that might have been a couple of hours, but now it may be more hours, half a day, full day, etc., etc. And as that builds up and builds up, that over time will lead to obviously an average increase in length of stay. But there's other factors there away from just that general flow within the hospital. There's delayed discharges, which I suppose is still kind of connected to that. And work we published back in March, last March, showed an increase in delayed discharges, but around 50%, roughly 50% of those delayed discharges were due to social or waiting for a social care package. There was elements within the system or within the hospital itself that was driving some of that delayed discharge. And then external to this kind of flow part, there is questions around workforce. So slightly elevated levels of staff absences compared to pre-pandemic. Obviously, a lot of clinicians and the workforce stressed and finding a lot of increased burnout from that real effort put in during the pandemic. That might have perhaps played through into a little bit of less workforce on the wards at any point in time. We don't have access to the data to fully analyse any of that, but that's suggestions that people have put towards us. And then the third element, and that's the one really that this analysis focuses on, which is on this ageing and ailing population. We've heard lots of stories of Britain is getting older on average, and with that getting sicker on average as well. So if that's playing through in the hospitals, we might see this increased length of stay. We know that the older someone is, the longer they likely spend in hospital, and similarly, the sicker someone is, the longer they likely spend in hospital. So all of this analysis is purely focused on this case mix, but I don't want to lose sight of other factors here that some of it we don't have data for, others that we still probably want to kind of look through, and happy to take some discussion and questions on that at the end. So just looking at case mix, we were able to look at both the age and this kind of ailing population. To understand that ailing population, we used something called the Charlson Comorbidity Index, and that was to try and calculate this level of clinical complexity. So these two graphs on the right show the proportion of emergency admissions classified as either severe or moderately severe clinical complexity. And we can see that in 2022, we see the highest proportion of admissions in both the moderate severe and then in the severe categories there. But I think what's actually the most interesting point of this is that we saw a year-on-year increase in clinical complexity for these two groupings. And 2022 wasn't much of an outlier at all. In fact, it followed the pre-pandemic trends almost to a point. So looking at the 2015 to 2019, what that trend was, 2022 effectively matched what that was. So there was no real sizable change from that pre-pandemic trend line. And that's probably quite interesting in itself, suggesting it, yes, the population is getting sicker. And we saw the same effect with the population aging too, but it's not any sicker or it's not any more older than what perhaps we would have expected based on that pre-pandemic trend line. And I do just want to pick up very slightly on when we're talking about patient complexity or this ailing population, and that's we can only really understand who was admitted to hospital. We can't really determine if the whole population is sicker as a whole. So if some of that stuff that I talked about previously in terms of people being treated outside of the hospital setting, if they are of less clinical complexity and they're being treated elsewhere, then that would mean that our concentration effectively of this kind of severe categories in clinical complexity would increase anyways. So we can't determine if the population is sicker, but we do know that our admitted population is sicker, just not any sizably different compared to pre-pandemic. So we just did a bit of a quick analysis trying to control for some of these changes in case mix. And what we found was that just looking at age and clinical complexity on their own, we were able to get a length of stay difference compared with 2019 that was 10% higher. So going back to that work that we did in June, we showed that it was 14% higher, or 1.1 days of a difference. Now, by correcting for age and clinical complexity, we find it's 10% higher, or about 0.9 days of a difference. So that does suggest that an aging and ailing population is impacting on length of stay, but it doesn't tell the whole story. And one of the, I suppose, the big things from the pandemic itself was obviously COVID-19, and how does COVID-19 play into all of this? So that's really where most of the rest of this analysis kind of drives into. So COVID-19 isn't included in the Charlson Comorbidity Index. Therefore, we had to try and find ways of coding that, or finding ways to code that ourselves. So we used the hospital episode statistics, and we used diagnostic data for that to be able to make accounts for the virus. To try and understand or compare 2022 versus 2019, we looked at non-COVID admissions in isolation. And this graph on the right shows how this kind of plays through over the kind of pre and then post-pandemic years in terms of change in average length of stay. And we've adjusted this for age and clinical complexity. And what we find is that in 2022, length of stay for non-COVID admissions and adjusting for age, adjusting for clinical complexity, was about 1.3% higher compared with 2019. So obviously a massive reduction from that 14% or even the 10% that we saw when we were looking at just adjusting for age and clinical complexity, but not adjusting for COVID itself. So this minimal difference, obviously 1.3%, and that's about 0.1 days on average. It's still something, but that minimal difference does suggest that COVID-19 can perhaps explain a lot of the increase in length of stay in 2022 compared with 2019, and probably something that most of you will already have thought of anyways. But I think just a really interesting point in this is that although we've seen quite a substantial reduction there, if you look at the pre-pandemic trends, so particularly the 2017, which is minus 2.5%, and that's 2017 versus 2016, and then 2018 and 2019, which are all showing on average about a 3% reduction in length of stay. What they're suggesting there, or what that data is suggesting, is that with an increasing aging population and with an increasing complexity in terms of population, we were actually seeing productivity gains or improvements in length of stay. So in some respects, the question could then be, well, why have we not then seen that also play through in 2022? And so people we've spoken to have suggested there's this almost 4% of a difference here. So the 2019 3% improvements in productivity, and then effectively in 2022 a 1.3% reduction in productivity. It's a kind of 4% difference there. And that 4% difference is probably quantified by those other factors that we've not quite looked at yet. So barriers to managing patient flow will likely have impacted on length of stay. Just thinking through COVID-19 a little bit more, although COVID-19 was obviously on the wane, or to an extent on the wane in terms of prevalence in 2022 versus 2020 and 2021, we did still see about 6% of hospital beds in December 22 were occupied by COVID-19 patients. It's not gone away at all, and in hospitals still relatively prevalent in many extent. And what this graph on the right tries to then articulate is for 2022, how we compare non-COVID emergency admissions with COVID-19 related admissions and what that looks like in terms of average length of stay. And again, we've adjusted for age and clinical complexity here. And what we see is that overall COVID-19 related admissions required hospital stays which were approximately 8.6 days longer on average than non-COVID admissions. So about twice as long people were spending in hospital if they had a COVID-19 related admission versus not having a COVID-19 related admission. We were able to, using the hospital episode statistics HES, we were able to break apart these total COVID admissions into a primary admission or a secondary admission. So if your diagnosis was diagnosis for COVID was in a primary diagnosis spot, then we've attributed you to the COVID or to the primary COVID-19 admission. If instead your diagnosis was in one of the secondary diagnosis spots, then we've attributed you to the secondary COVID-19 admissions. And we can obviously see quite a bit of a difference there in terms of average length of stay. Another part of this is how that plays through in terms of the proportion of admissions across all of that. And we saw that about 1/3 of COVID-19 related admissions were for primary reasons, and about 2/3 of them were for secondary diagnosis reasons. I want to just talk a little bit more in depth about what that means in terms of secondary admissions. So secondary admissions themselves means you can either be admitted to hospital with COVID as a comorbidity, but it could also mean that you've been admitted to hospital for non-COVID reasons, and then at some point during the time that you've been in hospital, you've contracted COVID as a hospital-acquired infection. We've not been able to really unpick the difference, or we don't access to our data doesn't allow us to unpick if you've contracted COVID or entered hospital with COVID or contracted COVID whilst you're in hospital. So that is one area of our analysis that's perhaps slightly obscured, and perhaps the data that you guys have access to more locally might be able to get more of that nuanced information. And I think I really wanted to bring that up there because this particular graph, I think, articulates that slightly better. So what we're showing here is the proportion of emergency hospital admissions across the length of stay in 2022. So what we can see is that as length of stay increases, the proportion of non-COVID-19 admissions reduces from about 99% at kind of 0, 1 day length of stay, all the way to about 62, 63% at 90 days length of stay. Primary COVID admissions ranges from about 3 to 7% across the whole period and fluctuates during that point. But secondary COVID admissions actually increases at the longer length of stay. So going from less than 1% at 0 length of stay to almost 30% at 90 days length of stay. So as I said, there's perhaps a slightly obscured part of this where we can't quite define whether secondary diagnosis of COVID is because it's a comorbidity upon entry in hospital or whether someone has acquired the infection during their hospital stay. We do obviously know that longer hospital stays increase the risk of hospital-acquired infection, and so that would perhaps heighten the risk of contracting COVID whilst in hospital. And it does perhaps lead into questions around infection control measures and whether we do need to do a bit more on that. But without having access to the actual data and really understanding the difference between those two, it's difficult for us to unpick some of that. And that's kind of a real quick fly through of some of our analysis. I've just got a couple of conclusions of where within the Health Foundation what we kind of thought was relatively apt and important in terms of next steps, but also messaging for a lot of this. And so what we're saying is that despite accounting for just 9% of hospital admissions, COVID-19 was likely a key driver to the increase in length of stay, but not driving absolutely everything there. This is an interesting point that our policy colleagues raised with us, which was many of the enhanced infection and prevention control measures which were introduced during the pandemic have now been stepped down. And the reasons for stepping them down were really to try and increase hospital capacity by having more beds available for patients, and also to try and improve productivity. And as I said, we don't quite have the data to back this up 100%, but if we do now see that hospital-acquired infections of COVID-19 is increasing, and some of that might be due to reductions or kind of stepping down of some of those IPC measures, then the ideals of increasing capacity and improving productivity might not be being seen because of some of that. But as I say, we don't quite have the data to fully articulate that point at this point in time. And then, on perhaps a slightly positive note, is that the future trajectory of the virus will likely have implications for NHS productivity. So if we start to see, and as we have seen in 2022, the virus not being quite as potent as it was during the height of the pandemic and not being quite as virulent as it was at points during the pandemic as well, then we might see a bump in NHS productivity as fewer people are admitted to hospital for COVID-19, which, as we're suggesting, perhaps takes twice as long in hospital compared with non-COVID admissions. Then we would see this bump in productivity there. But on the other side of things, if we actually see the virus becoming more potent, a more potent strain emerging, then that might have some negative implications to productivity. But at the Health Foundation, we're not virologists or anything, so we can't, again, totally state those claims. But based on the statistics that we've shown or seen and shown here, hopefully that kind of makes sense of where some of that does play through. And then just the last thing that I wanted to mention was that although COVID-19 is obviously a driver of that kind of increased length of stay from what we've seen, we did see that 4% difference still playing through compared to the pre-pandemic trends in productivity improvement. And so that really kind of leads me in opening the floor up to questions and thoughts and discussion here around what some of those wider system factors that we suggest might be a patient flow through the hospital likely contributed to that average increase in length of stay, and what we can maybe try and do there to better understand what a lot of that is. And that's my presentation. Thank you very much. Hopefully it was all right and not too wordy or such like.
No, that was perfect. Thank you, Andrew. Thank you very much for your Thank you for coming, and thank you for sharing your work with us. It's probably one of your first, as you say, your first pieces of work at the Health Foundation. No, that was really interesting, and so relevant to a lot of people. I've got one comment which has been put on the questions on Menti, which I'll raise in a second or two. So I'll just allow people to digest, and then they may have some other points for you. I did wonder if there were, so that you put out a couple of effectively questions around the coding of, for example, COVID as a comorbidity. And so you've had to work that out. I guess other researchers have as well. You've had to work that out from the data, how you would use the ICD-10 codes and the position and what have you to quantify those. So I suppose that is a big thing, isn't it? So somebody comes to hospital. I mean, also they have long COVID. You know, is that a comorbidity that comes with them? Are people tested routinely in hospital for COVID still? So again, these are I don't know, just as you don't know, but there may be people, might be some analysts here, some hospital analysts who have a better idea about what happens in terms of monitoring COVID within sort of a hospital setting. We'll see if they want to talk about it in a minute or two. The comment which was there's a couple of comments which have been put on Menti, and I'm going to get awfully lazy now actually, so I'm going to share my screen. Andrew, and you can pick out the ones that you want to talk to first. So I will do that right now. There we go. Can you see?
Sure. So maybe just on some of these Charleston questions then. So we've been sort of the Charleston, how do we start to use that with our data? I've been using R Studio to do a lot of this analysis. So there is a Charleston package within R Studio that you can use there. And I'm happy to share the code and such. So the code for all of this analysis is public. So we can share some of that, particularly for R Studio to use that, but I'm happy to kind of share our kind of code for it to be able to build it. We obviously interrogated a lot of what that was doing behind the scenes to make sure that from what our literature was saying for what Charleston is and how that's calculating each condition and what that score would provide, that we were able to kind of match that up when we were doing it ourselves. But there's a package there that's available that I can share with you.
Yeah.
The other kind of Charleston question around how confident are we that it's not increasing due to improved coding over time? It's a really good question. I think it's a hard one to answer specifically, other than I think this goes to any question of any way that we want to try and understand comorbidity or understand complexity, that if clinicians themselves, if they are coding it more accurately over time, then that would change no matter what index that we're using to try and look at it. And I think that was something that we did discuss internally, particularly of using things like HRGs instead to try and understand clinical complexity. But again, there's been kind of variation over time of how people have coded that and what people then put through for the financial side of things there. So it's I suppose it's a factor we need to take into account of our analysis, but one that I would imagine no matter what, you'd see that playing through. But hopefully between 15 and 19, if there was changes in terms of the way people were coding or such, it would be relatively, but I can't comment on how minimal that would be, but something we just need to accept to some level. Hopefully that's me waffling, but hopefully that kind of answers just to some degree. So this question around the case mix, which says that most of the increase was due to case mix, not COVID, with the next slide, which suggests it was mostly COVID. So I'm not sure maybe if that's the way that I've discussed the numbers, but what we saw, if I take three numbers here, so the first one was this 14%, which was comparing 2019 with 2022, and that was the increase there. What we then saw, the difference between 2019 and 2022, looking at age and sickness, was 10%. So that's like a 4% shift there. But then if we look at including COVID itself, then that goes from 10% down to 1.3%. So a 8.7% difference versus a 4%. So yes, we do see, I don't know if that helps answer that question, if I've made it slightly better there of trying to articulate it, that from the 4% difference when we're just looking at age and clinical complexity, and then taking that and COVID as well, added on a further 8.7% of a difference. Hopefully that makes sense, but feel free to come back if that, cool, I think that's a thumbs up. Hopefully that's all right. So this question on building new morbidity indices that incorporate the effects of COVID, I think, Rachel, as you mentioned, things like long COVID that we'll only have captured if we're capturing COVID within the system. But if you're coming in with a respiratory condition and such like, then we won't have seen any impacts, or we won't have contributed to that. So I think definitely there's probably a case for building in some sort of COVID feature. I think this also leads to a longer question of, is COVID here to stay, or is it something that will transition in somewhere next? So I think that's part of the question. But from what we were looking at, yeah, I think that would be really helpful to have COVID included. But is it something that's only here for the next 5-10 years perhaps, and not going forward as well, that other conditions we've also looked at are much there for the longer term? So it really depends on, I suppose, going back to the virility of where does COVID take us next. Question on, can you share your published research from June and December? So both papers are currently available on the Health Foundation website, and the code should be available through that as well, but I'm happy to share that separately through the network as well, if that would be helpful.
Okay, good.
What analysis have you done to isolate the impact of COVID from other factors such as discharge complexity, age, and frailty? So we did look at COVID in isolation, particularly from age and clinical complexity. When you talk about discharge complexity, I'm not sure if that's relating to some sort of delayed discharge or discharge to places. But we did look at COVID in isolation compared to age and clinical complexity. I couldn't remember or tell you what the numbers are for that, but that was really where the analysis started to come through for us, that we saw COVID was this big factor in itself. And then I think the way we've tried to articulate it both here today, but then also in our paper from December, was that age and clinical complexity we want to talk through themselves, but then we did want to add in this COVID as an added extra on top of that. But we did do things on COVID, and that was where in isolation, and actually where it kind of first came through. Frailty is a good question though, and that's something that we do want to look at going forward as well. That was raised with us when we published our paper in December. There's, I suppose, a question as well, particularly age, frailty, COVID, clinical complexity, how much of all of this does it tie in? So things like inequalities that we looked at, but we found a lot of that was a kind of confounding factor to some of these other features. So whether frailty itself has an individual impact or whether it's a confounding factor, but that's something we definitely want to look at this year. So sorry, 2023, that's a great question, because that's, yes, we definitely want to reverse this analysis at some point this year. And I was meant to say during our paper, during the kind of talk there, that 2023 was showing similar trends, but we don't have the conclusions for that. So yes, we want to see how that's played through. We saw that COVID-19, I think, was about 60% the size of what it was in terms of bed occupancy in 2023 December versus December 2022. So continuing to see a reduction, but yeah, definitely something we want to refresh this year. Would it be possible to create a chart that apportions the increased length of stay to case mix, COVID, and productivity losses? I think that talks to slightly to one of the questions previously, that we did all of this in isolation. So yes, I think definitely for case mix and COVID, we could, I'm only slightly hesitant, we could do most of that of trying to attribute each part of it. The only slight concern being how much of it is confounding factors as well. But that's something we can definitely look at. I'm unsure the third part on productivity losses, if that's related to that kind of missing 4%. And I think this is just one slight, if that is, the one slight concern that we have, I think, with all of this is that we didn't want to say COVID is attributable to 8% of the difference. This is attributable to that kind of thing. That's why we think with a lot of it, we've tried to group it up in a kind of aggregate. But we could have a look at something like that and see if we can. I think just our slight concern is how much of it is then people saying this is this, this is that, rather than kind of in the round, which maybe is a more political answer to it. Is your code for this analysis published in GitHub? Yeah, it's publicly available on GitHub on the Health Foundation areas if you've got access to it. But again, after this, I'm happy to share that. Great question or point about the diagnostic tests and scans take days to organise. And I think this is the limitations of our data that we have access to, that it really just shows you enter hospital, you have these diagnoses, you leave hospital. And we might see each transition in terms of wards that you go to, but we don't have access to that kind of richer intra-hospital activity, which really where that barriers to patient flow comes in. So yeah, that we can only look at it from this kind of aggregate level, but if we were able to get understanding or kind of the information around each of those individual parts, we could kind of build that in. But it's definitely a factor. We just can't articulate how big of a factor that we think that is. And then just this last question about in your average length of stay calculations, did you include zero length of stay? So we didn't include zero length of stay in our length of stay calculations. I think I've included it in some of the graphs just to kind of show that variation in terms of admissions. But when we're doing our calculations themselves, they didn't include zero length of stay. And that's for things like the same day emergency care. So I think there's someone's raised a hand.
Yeah. So Michael.
Oh, thank you.
Okay.
It's just, I'm a geriatrician at Nottingham, actually. I work with Richard Brooks, who's one of our analysts here. And he raised the point about the discharge pathway, which is, so we've been doing a bit of work about our length of stay here at NUH at Nottingham. And actually, one of the things that we've been trying to work through, and we've done quite a lot of work so far, but one of the barriers is that length of stay in hospital is inextricably linked to the delays in transfer of care. So, you know, and that's what the pathway 1, 2, and 3, the discharge to assess pathways. I'm not sure if you've got any further, anyone's got any further with looking at those community delays in terms of social care or community beds, care home admissions, because obviously during COVID, the community sector took a massive hit, and there's still a lot of recovery. A lot of staff left or moved on or furloughed or whatever it was. And I'm not sure we've got a grasp yet of what's going on that side of the fence, but because I say that makes a big difference to length of stay. And by the way, great presentation. We found exactly the same thing about COVID here. One of the biggest factors was COVID. And again, that's because if you think about COVID, you have to isolate them and keep them in for 7. It used to be 14 days, and it was 7 days. But that additional length of stay built into the COVID diagnosis, particularly for secondary diagnosis, if they've been in hospital already for 5, 6 days, then you add on the isolation period. That's where that extra spell comes from. But sorry, that we mirrored exactly what you're showing with COVID. But I think there are some nuances around the D2A and what's going on in the community. So not sure if you've got any ideas on that.
Sure. So I'll just thank you for your question. I'll just preface very quickly by saying, so I started here last June, and before that, so I'm Scottish, and so I've worked in the Scottish system. So similar things, but I couldn't obviously tell you all the parts of delayed discharge and such like. But I think maybe to slightly answer your question, so we did do a piece of analysis back in March last year that was around delayed discharges, and I think this is maybe just to give you a slight overview of what we've kind of been approaching this of length of stay, which was this kind of length of stay is going to be the last point of this analysis. It really started with kind of ambulance ramping last winter and what was causing people to be not getting into hospital in the first place. And then that was then leading into delayed discharge, was the kind of people can't get out the other end. So then that leaves us the inability to have beds available for people to get into hospital. And that was the analysis that they showed back in March, was around 50% of delayed discharges were due to waiting for a social care package. And I think the lack of social care data, again, I'm speaking from a Scottish perspective, but I'd imagine from a UK-wide one as well, the lack of data there doesn't quite allow us to fully understand if we were to increase social care by X%, what would that do to delayed discharge, kind of building some sort of correlation from it. But the delayed discharge, when we saw that it was about 50% of them were waiting for some sort of social care package, there was still that 50-ish% that it wasn't due to that. So that can either be complex reasons, or they're waiting for assessments and such like within the system itself. And then I think the previous person that asked around diagnostic testing and stuff, there's many delays that wouldn't be counted as a delayed discharge. So that then led the team to go from focusing on delayed discharges to, well, there is this wider length of stay piece that we want to go to, and then naturally where I've then come in after that of, can we understand what those drivers are? So yes, delayed discharge does have a major impact, and trying to understand how the changes in social care kind of post-pandemic is definitely something that we don't quite have the data for at that kind of aggregate level to be able to understand how has care home beds changed pre versus post-pandemic and the need for that. But that's definitely somewhere that we'd want to try and, if we could, unpick it. And I suppose that's more of a local level, that would be working with a couple of trusts perhaps and trying to see, looking at hospital data, linking that patient pathways effectively with the delayed discharge then into the community setting, and can we see how that has varied over time. But from a kind of national data collection that I've been working with at this point, that's not been quite feasible to kind of unpick it. But yeah, delayed discharge is really important.
Thanks, Andrew.
Yeah, thank you, Andrew. Thank you, Michael, for your question. It's good to see your results were, well, it's good in a way to see your results were were the same or similar. So my only sort of further question really, Andrew, is well, when you've done the update, you can come back and share the results from that. That's a given. Is so, and you've kind of you've covered it in some of the conclusions that you drew to at the end of your presentation, at the end of the analysis. So how do we use this information to, what do we do, what can we do with this, with your findings in practice? How can people use it practically to change the way they do things, or is it really just a stepping stone to more analysis so we can get some more information in order to do that? What would you, how are people going to benefit from this information?
Sure, it's a big question.
I know.
I think,
Sorry.
No, it's all right. So I think, well, actually, I have another hat that I wear as well. So I work for Gordon Brown in Scotland, doing kind of how we want to think about the future of health up there. So there's,
Right, okay.
I suppose there's that kind of element as well to some of this. I suppose with this particular analysis, we've not shown, I think, the kind of what are the levers that a trust or the country, any politician or any such like can pull. What we have tried to articulate is that COVID is still a very important part of that. And so things leading towards further analysis, and that's a cop-out in this point, but I will go on to the next bit. The cop-out being, well, we need to understand, how does secondary diagnosis, how does that impact particularly the hospital-acquired infection? Is there something that trusts and hospitals themselves need to do in terms of trying to reduce hospital-acquired infection? Is that any more elevated than it was pre-pandemic? And so is there something there that kind of does need to be done? Obviously, the kickback to that is there'll be fewer hospital beds available, fewer workforce available to be able to do such a thing. The other side is, and again, it kind of ties in with some of this analysis that we need to do next of, well, what is the analysis that we can do of in trying to reduce length of stay going forward? So we might see this big bump in 2023, and then perhaps in 2024 if the pandemic does, or sorry, COVID-19 does wane a bit further. But is there other factors thereof that we need more beds in the system, or we need increased virtual wards or same-day emergency care? It's about social care. So there's a wider question as well that we really need to try and get, and that's kind of what I suppose our plan for this year is trying to understand some of these other factors, even things like sickness absence. But how does sickness absence compare to number of managers that are in the system? Does that have some sort of correlation and impact there, that the more managers, then people maybe feel more supported in work, and or not? So there's a vast range of questions for us to look at, I think, over the next 6 months to this year or so, that would hopefully then provide more solutions or answers of, and it's more correlation than causation perhaps, but there's this, we've seen this here and we've seen that there, and it means if we pulled this lever, pulled that lever, then we might see some impact. But just referring, when I said about the Brown work, so back home we're having to find cuts of about £1.5 billion over the next year or so. And so if I say, well, we just need to have more managers, more doctors, more nurses, or we need to have more beds, that's not what's going to happen in reality either, and we won't see that for the next few years at least. So there's an element there of, well, what can we do and how do we need to try and better fixate on what that is. So that's also, I suppose, our plans for the next kind of 6 months to a year with the current financial circumstances and constraints. Is there things that can be done to try and improve it? But the slight ending positive note is we hope that if COVID is going to continue to wane, if we see that in our 2023 data, then hopefully we start to see a bit of a kind of productivity bump, and then hopefully that would kind of lead to improved access to care. Hope that kind of answers it slightly, your question.
Yeah, it's complicated.
Yeah.
And you need to do some more work, and we're learning all the time. The more you look, the more you find, and then you find sort of different avenues that you need to cover. I just touch on what Michael mentioned, that workforce issue post COVID is the thing, and it's, you know, it's difficult to measure from the data available nationally. That I imagine there's lots of case studies which was local examples which will kind of sort of confirm some suspicions and things that people have raised as well. Someone's just saying, and just on the comments there, thanking you very much for your presentation and the very well written article on the Health Foundation website. So they're making good use of their time here and doing a bit of research on the Health Foundation website, and they will find both of those papers that you've mentioned. But I'll share them. I'll pop them on the website, and I'll share them with everybody afterwards, because I think they're definitely worth having a look at. Okay, so I've just got this feeling that we can talk about this all day, and I have missed somebody's comment in the chat. I'm sorry, so I don't think you can see the chat, can you? No. So I'll share that point with you later if it's a question that you can answer later. But meanwhile, thank you again, and I'm just going to share my screen again, and I will move us on a little bit to not more questions, don't worry, you're off the hook now. I just want to tell people about what we've got coming up in the next few huddles. So we've got the next huddle is about estimating the impact of population and morbidity changes on healthcare utilisation. So that's Paul Seamer from Strategy Unit. I think that's been confirmed. If he's in the audience now and this is a massive surprise to him, just put your hand up and say, whoa. So I'm looking forward to that. We've got a session from somebody in NOTS who's going to be talking to us about automating and backing up of SSRS reports when changes are made. That's in a couple of sessions' time. We've got a session on community service contracts about the supply, equity and impact of those, and that's another Strategy Unit colleague. And just confirmed this morning for sometime early May is demand forecasting for executives and professionals, aka the session or a similar session to that which was done in Hacker 2023. There's a couple of other ones there which I'm personally very much looking forward to, and I should say I'm also looking forward to Hacker 2024. So if you haven't already registered your interest in that, then why not? And also please do. And it's on the 23rd, 24th of July, and that's in Telford International Conference Centre. So change of locale, venue is excellent, and look forward to seeing you all there. So get yourselves registered so we can tell you all about it. Keynotes are filling up fast. Hannah Fry says she can't wait to come and spend time with us. Actually, she hasn't said yes yet, but she might. You never know. She has in the past said she would like to join us for some of our sessions. And I'll just sort of finish here today a little bit earlier than normal, just by saying the up and coming training opportunities that we've got is the introduction to Git and GitHub, which is one of our many highly rated training sessions, and that's with Zoe Turner. Professor Mohammed is delivering his training on understanding and reporting of hospital mortality statistics, the ever popular training session that you need to attend if you actually want to understand what mortality statistics are saying and actually what they're not saying. That's quite important as well. And then we have a face-to-face session around the introduction to decision quality. So that's Fraser Batty, and that's on the 6th of March, and that's in Birmingham. Really can't recommend that highly enough, and we do have spaces, so if you're able to get to Birmingham, It's just literally 2 minutes from the train station, and the lunch is excellent. Highly recommend that. And Bullet 5, that's interesting. That's my most favourite training session that's coming up. Is called Bullet 5. I don't know what that is. It's clearly something I had in my head, and I didn't finish that. So okay, I'll come back to the room. It's just obviously as usual. If they got any more, I don't know what that is. Anything mentioned today, you want to find out more about that, then please just get in contact with me. And I would just like to say thank you again, Andrew, for coming today, and thank you everybody for coming. And I'll see you all in a couple of weeks.
Thanks so much for having me. Thank you.
Pleasure.